appreciate the fact that you are all interested in hepatitis B. It's not something that everybody is interested in, but it is really important, particularly for the vulnerable communities in the U.S., and we want to make sure that everybody gets taken care of. So I'm going to move ahead to the first slide. There we go. Okay. Hepatitis B is an incredibly common infection. It's actually one of the most common infections in the world. About 1 out of every 3 people worldwide is exposed to the virus at some point in their life, usually at birth or during early childhood. So 1/3 of the population, that's a huge amount of people who are exposed and initially infected with hepatitis B. Hep B can cause both acute and chronic infection, which means that of the one-third of people in the world who are infected, most of them will recover. But about 240 million people right now are chronically infected. So when someone is newly infected with Hep B, we call it an acute infection. And most people, their immune system is able to fight it off. If someone is unable to fight the virus, then they become chronically infected, which means their immune system's not able to fight off the virus. And for the most part, these people will be infected for life. There is no cure for hepatitis B right now. So once someone has a chronic infection, they generally stay infected even with treatment. Hepatitis B is transmitted in very much the same way as HIV. You need direct blood-to-blood contact. It is highly sexually transmitted, and it is also transmitted from mother to child during the childbirth process because of the blood exchange that happens. And so throughout the world, mother-to-child transmission is the most common route of transmission. And the biggest problem with that is there's a direct correlation between age of exposure and chronic infection. So the younger someone is when they're infected, the more likely they are to develop a chronic infection. So when a baby is exposed at birth, there's a 90 to 95% chance that they will stay chronically infected. And that risk actually goes down with time. So when someone is infected as an adult, it's the exact opposite. About 90% of adults are able to recover. So obviously this is a big issue, and one of the things that around the world we are trying to stop. And there is a perinatal post-exposure prophylaxis program that is put into place in most countries now worldwide, although not necessarily everywhere. So when a baby is born to an infected mother, the baby receives the first dose of the hepatitis B vaccine, and they also receive a dose of immunoglobulin, hepatitis B immunoglobulin, which is basically high dose of antibodies. And if the baby receives those 2 shots at birth within 12 hours and then completes the vaccine on time, then there's a very good chance that they won't be infected. So that prevention program actually breaks the cycle of infection from mother to child. And we're going to talk a little bit more about how we do that in the United States and how effective it is. There is also so obviously there's a safe and effective vaccine. All of you are in med school, so you've all probably been vaccinated at some point. And you're all young, so that's another thing. In the United States, the hepatitis B vaccine has been routinely recommended for babies at birth since 1992. And it is mandated in most states for school entry. So in most states, you need the hepatitis B vaccine in order to get into school. Now that being said, not 100% of kids in the U.S. are vaccinated because there are certain exemptions. It's estimated that about 90 to 95% of kids receive the vaccine at some point during childhood, which is not bad. So like I said, there are about 2 billion people exposed to the virus in the world, and about 240 million who remain chronically infected. So you can see from this map the areas that are light green and dark green. So the areas that are light green, those are areas of the world that have intermediate risk of infection. That means that about 2 to 7% of the population in that area is infected with Hep B. Oh, what? That was weird. Okay, let's go back. And the dark green areas of the world, those are high-risk areas where greater than 8 of people who live in those areas are infected with hepatitis B. And then the gray areas are considered to be low risk, where less than 2% of the population is infected. You could see by looking at the map that most of the areas of the world are intermediate or high risk, and this just shows you how very common and how much of an issue hepatitis B is in the world. In the United States, it's estimated that there are 2 million infected Americans. This is potentially an underestimate. So and this is something that not everybody knows, but going into healthcare, it's good to know. We do not have routine surveillance for hepatitis B in the United States, especially for chronic hepatitis B. So it is very hard to know exactly how many people have hepatitis B because CDC is not routinely surveilling it. They don't have the infrastructure or the funds, and it's not necessarily a priority to them, unfortunately. So when we say 2 million Americans are infected, there's a couple of publications out there, and I put them on the bottom of the screen, that you can read that talk about the underestimation. And that number it was a mathematical model that we've put together based upon the prevalence of high-risk groups in the United States and from their country of origin. And I can talk more about that later if you'd like me to. We also know from immigration data that about 40,000 new immigrants come into the country each year who are already infected, and that there are an additional 20 or 30,000 infections happening in the U.S. each year. So there's still an incidence of infection in the U.S. even though we have a vaccine. And what that tells us is we're not adequately using the vaccine, at least in the United States. We shouldn't have any new infections here in the U.S. Now, to say we have people who are coming over who are already infected, that's one thing, but we certainly shouldn't be having new infections in the U.S. These are two graphs that I like to show. A lot of what we hear publicized about hepatitis B in the U.S. is that we've done a great job, it's almost gone. And so the CDC likes to talk about the successes, and I agree we should talk about the successes we've had. But one of the things that we have to remember is when we talk about the successes associated with hepatitis B in the United States, we talk about the reducing incidence of Hep B only acute. So if you look at this top graph that shows the reducing incidence of Hep B, this is acute hepatitis B, and it is a direct result of the vaccine program in the U.S. So while we are doing a really good job of addressing acute hepatitis B in the U.S., we have seen about an 80% decrease in acute infections in the U.S. Chronic hepatitis B infection is not decreasing at all. It is either remaining the same or it might even be increasing. So that's something I like to point out to folks because it does look like we've done a really good job, and in some cases we have, but that's really only for acute hepatitis B. So why is hepatitis B an issue? Why do we care? It is one of the leading causes of death in the world. It's actually, depending on the year that you look, it's the 9th or 10th leading cause of death worldwide. Causes up to 700,000 deaths each year. And it is considered to be the second leading carcinogen after tobacco because it causes so much death. Outcomes of chronic hepatitis B infection include cirrhosis, liver failure, or primary liver cancer. And the primary liver cancer is what is causing most of these deaths. About probably 400,000 to 500,000 of them are from hepatocellular carcinoma or primary liver cancer. Obviously, this is something we want to avoid, and so we're going to talk a little bit more about ways that we can do that. And what we know is that up to 25%, so about 1 in 4 people who are chronically infected, who are infected at birth, will potentially die prematurely. Now, this number is not from the U.S. This number is taken mostly from around the world, and that it doesn't account for screening and treatment. So this is the percentage of people who will die prematurely if we don't do anything. So if people aren't screened and they're not treated, this is what would happen. And this is what we used to see before we had treatment. hepatitis B has significant health disparities in the United States, and I'm sure you figured that out already just by looking at the map of the world. Hepatitis B and liver cancer both represent the single greatest health disparity for Asian Pacific Islanders in the United States. So if we have about 2 million people in the U.S. who are infected, about 1 million of them occur in Asians or Pacific Islanders. So they carry about 50% of the burden in the United States, which is huge. As of last year, primary liver cancer moved up to the second leading cause of cancer death worldwide. It has devastating impact and a very short survival rate. And among Asian and Pacific Islanders, particularly Asian and Pacific Islander men in the U.S., liver cancer rates are much higher compared to other groups. So you could see 13 times higher in Vietnamese men, 8 times higher in Korean men, and 6 times higher in Chinese men. We are starting to now do some research in African and African immigrant communities. And what we're finding is there are infection rates that are just as high as they are in the Asian Pacific Islander community. So we are also now saying that hepatitis B disproportionately infects African immigrants as well because of the high rates in Africa. There are still some significant gaps to addressing hepatitis B in the U.S., and it is these gaps that we are trying to address at the Hepatitis B Foundation and Hep B United on a daily basis. What we know in the United States is that only 25% of chronically infected individuals are aware of their disease status. Most have not been tested, and most do not know that they are infected. Because it is a silent disease, very often people can live with it for decades without knowing that they have it. And I don't know if you've had, if you've gone through what's part of a routine checkup, but hepatitis B is not routinely tested for at the primary care level. So it's not part of routine testing right now. And we're going to talk about who is recommended for that kinds of testing. So only 25% of chronically infected individuals know about their infection, and less than 10% of all infected individuals are accessing treatment. Obviously, there is a lot of room for improvement. This is the care continuum that we created at the Hepatitis B Foundation. We published it back in 2011, and you can see the significant drop-off here. If we have this gives the low estimate and the high estimate. So if you have about 2 million people in the United States who are infected, you can see there's only about 400 to 600,000 people who know they have it. Of that, about 300 to 500,000 would be eligible for treatment, but only 200 to 300,000 are entering into care, and we know only about 50, actually the number is more like 50 to 70,000 prescriptions are written each year for hepatitis B. So this is a really nice visual way of showing you there's a lot of room for improvement. We really need to get those other bars up to the number of infections. I know you wanted me to talk a little bit today about what some of the barriers are to screening and linkage to care. And so the next 2 slides show the results of qualitative studies that we have done in Philadelphia. So we did focus groups and interviews among the Asian communities in Philly. It was Chinese, Vietnamese, and Korean communities in Philadelphia. We asked them, so we did focus groups, interviews, and surveys, and we asked them a lot of questions about what kind of care they were getting and what was stopping them from getting hepatitis B testing and care. And then we took those data and we added to it by doing a literature review. And this is kind of what came out of it. So this is from the individual's perspective, from the patient's perspective. You could see there's a number of different barriers at every different level. So there's individual barriers, there's organizational barriers, there's community barriers, and when you put it all together, it becomes a significant issue. From an individual perspective in Philadelphia, I think we have seen a lot, there's a couple of different issues that stand out. One is stigma and discrimination related to hepatitis B. What we heard over and over again is that people often didn't want to be tested or didn't want to seek out care for their hepatitis B because they were afraid of what the backlash would be. They didn't tell their family, they didn't want their family members to know if they did have a hepatitis B infection because they were afraid that they would be shunned or that they would be considered unmarriageable or that they would be considered a burden on their family. And so those kinds of long-standing stigma-related and cultural beliefs played a big role in why people didn't want to get tested or why infected individuals didn't seek out care. Obviously, finances were an issue. People who didn't have money for screening and treatment, or more than that, what we saw were people who were working in shifts. So they were either working in Chinese restaurants or working in factories, and because of the shift work, they were unable to take time off from their jobs because if they took time off, they wouldn't get paid. And so this was a financial and a work constraint that we saw. And then in general, we saw a lot of issues with people who didn't know how to navigate the healthcare system. So even people who wanted to be tested or wanted to seek care, they're not familiar with the healthcare system in the U.S. and they just didn't know how to do it. So those are all kinds of barriers that we are now working to overcome. Okay, so this slide talks about the physician-related barriers to hepatitis B screening. We did not collect any of these data personally in Philadelphia. This is all a result of published literature. So we did a bit of a meta-analysis back in 2013, I think, at this point, and we tried to figure out why are physicians and other healthcare providers not screening for hepatitis B, and this is what we found. So the culture was definitely an issue. Physicians were more likely to screen their Asian patients if they were Asian themselves. And when there was a cultural discord between the provider and the patient, they were less likely to be screened, especially when a provider thought that their Asian patient couldn't handle a diagnosis. So sometimes it was they didn't speak the same language as their patient, so they weren't sure that they could communicate with them and tell them effectively how to handle their hepatitis B. They didn't think that their patient would be able to understand their test results or afford the treatment for it. So a lot of this is just a perception issue and a provider-patient communication issue. But also, there appears to be low knowledge about hepatitis B, Hep B in general, who to test, how to interpret results, and what to do if you find someone infected. And at the primary care level, this is a problem because we know that primary care providers really have to think about tons and tons of conditions and diseases. So when someone who is high risk walks into their office, they're also high risk for many other issues, right? So hepatitis B may not be at the top of their list of diseases that they're thinking about. And for a lot of providers, they may have only seen 1 or 2 cases of Hep B because they're not routinely testing. And so there is a definite lack of knowledge that's been published in a number of countries, but in the U.S. especially. What we know is that when a patient asks their provider to be tested, they're 5 times more likely to get a test for Hep B. When you have both a provider and a patient who are prompted for a Hep B test, they're 8 times more likely to be tested. What that means is if we want to increase the number of high-risk people who are tested in the U.S., we have to educate and change the behavior of providers, and we have to educate and change the behavior of the patients or the high-risk individuals as well. So you really need to do it from both sides. What do we need to reduce the burden of Hep B in the U.S.? Well, the big picture here is we need to improve screening, right? If only 25% of people know their status, we have to get that up to 100, and we can get that up to 100. And then we need everyone who is infected to get appropriate care, and this turns into a healthcare access issue. What we know is that the people who are most likely to be infected are also the most likely to be underserved. So they're the least likely to have health insurance. They're the least likely to have a primary care, a family doctor. And they're the least likely to seek preventive medicine. So we need to make sure that not only are we changing behavior and educating people, but we actually have to work from a systems perspective and make sure that people are getting access to care and treatment. Obviously, we need to do a better job with vaccination, not only in the U.S. but globally. And we need to prioritize hepatitis B so that there's more funding and more research and more education and awareness. I'm going to talk both about CDC screening recommendations and then about the USPSTF guidelines, and they go hand in hand. In 2008, the CDC Division of Viral Hepatitis published their hepatitis B screening recommendations. And this is basically high-risk screening. So it recommends screening for people who are considered to be at high risk for Hep B infection. So almost anyone who is born outside of the country, because we saw that map, and almost everybody in the world is in a high-risk group, high-risk country. So people who are born in areas of the world where prevalence is greater than or equal to 2%, and then children, so U.S.-born people whose parents were born outside of the country in high-risk countries should be tested as well. And then it kind of runs down the list. People who have HIV should be routinely tested. IV drug users, so this is really interesting. There was an MMWR published, I think it was 2 or 3 months ago, that because of and I'm sure you guys have heard about this, because of the increase in injection drug use, acute Hep B infections among young people have increased for the first time in 20 years. We have not seen an increase in acute Hep B for 20 years until now. There was, and this was talking about an epidemic, a new epidemic of hepatitis B and hepatitis C in the Appalachian region among, I think it was 18 to 25-year-olds who, because of injection drug use, they wound up getting infected with Hep C and often with Hep B as well. Now, had they been vaccinated as babies, this would not have been an issue. So this kind of highlighted something for us. Clearly, we're not doing as good of a job as we should with routine infant vaccination, because all of those folks who are 25 and younger should have been vaccinated. These are the new USPSTF recommendations from 2014. So for those of you who don't know, just excuse me one sec. Okay, for those of you who don't know, the United States Preventive Services Task Force is an independent group that creates recommendations for preventive care services in the United States. And they grade preventive care services based upon evidence. And then based upon that grade, health insurers in the United States decide what they're going to cover or what they're not going to cover. And this can include private health insurers, Medicare, and Medicaid. So in other words, USPSTF recommendations are very important because it tells, not only does it kind of tell providers what tests to run, but it allows them to get paid for those tests, which is really important. And in 2014, for the first time ever, risk-based screening for Hep B infection got a grade of B. That's a really good grade. So typically, preventive tests are covered if they have a grade of B or A. What this means is now for the first time, testing for Hep B based upon risk should actually be paid for. It takes a couple of years to roll this out, but it's good news for us. I wanted to point this out. We talked about the link between hepatitis B and liver cancer. Last month there was a new publication. It was the annual report to the nation on the status of cancer. And this report focused on the increasing incidence of liver cancer in the U.S. So this documented that primary liver cancer is the only cancer in the United States that is rising in both men and women in both incidence and mortality. That is a really big deal. So you could see there's about 28,000 diagnoses in the U.S. and about 22,000 died. So those data were from 2012. So obviously you can see almost as many people die from liver cancer as are diagnosed because there's such a low cure rate for it. There's also disparities in men versus women. Men are way more likely to be diagnosed with liver cancer, and that is not surprising because men are more likely to have chronic Hep B infection than women. The 5-year survival rate for primary liver cancer is 16%, and this is really important. they found that hepatitis B testing and treatment is associated with a reduction of liver cancer risk from about 50 to 80%. That is a huge potential reduction in liver cancer risk, and just offers, number one, this report tells us just how important it is to be addressing Hep B right now. And it also tells us how successful we can be. If we get people screened and into care, we really can see liver cancer reduce in the U.S. Oh, okay, so I'm going to switch gears a little bit, and I don't know how much any of you know about the Hepatitis B Foundation. I put these slides into every presentation. This is our home. That's our building. The Hepatitis B Foundation, we are a national nonprofit organization. We've been around for 25 years, and we have a bunch of different arms. So in this building here, which has about 125,000 square feet of research space, we have labs and over 50 scientists now who are working on a cure for Hep B and also early detection methods for liver cancer. So that's a major goal of Hep B Foundation, is to work to find a cure. I'm in the public health team, so we have an outreach team that works on educating people. They reach about 1 million people a year, and they also directly serve about 3,000 people each year, people who call us or email us who have questions, and we help them get care, we give them information and support. And then I'm on the public health team, where we do public health research mostly on health disparities and linkage and screening and linkage to care. We do have a national research and advocacy program, and I know you guys know Hep B United Philadelphia. So Hep B United is kind of a national umbrella. It's a coalition right now that Hep B Foundation runs. It's in 22 cities in 13 states. And we are all working around the U.S. to try and raise the profile of Hep B and liver cancer. And primarily, we're trying to work in highly impacted Asian Pacific Islander communities to increase testing and care. And that is what we are doing in Philly. So Hep B United Philly is our local coalition. Pavitri manages that coalition, and as you know, because I think we're doing a screening with you in a couple weeks, we do community-based education, we do community-based screening, and then we also have we do a lot of awareness events in Philadelphia, and we try and work with local city leaders to increase prioritization of Hep B. This is a picture. Oh, so this is the Hep B United map. It shows what states we're in, and this is a picture of us last year. So we do lots of advocacy. One of the things we do is a Hep on the Hill Day, and then in July for World Hepatitis Day, we bring hepatitis B speakers and leaders and advocates from around the country, and we go to Washington, D.C., and we meet with legislators to try and improve the funding and the prioritization of hepatitis B in the U.S. These are some of the materials that we have. We do work with CDC on a multilingual national campaign. Right now it's in 4 languages. If you are ever going into the community and you wanted to bring materials with you, these are all free and they're printed. All you have to do is order them online, or you could even, I have tons of them in the office, I could even give them to you. There's posters, there's fact sheets, and then they have radio and TV PSAs and all kinds of fun stuff. These are just some pictures from Hep B United Philly. Again, I put this in there. I know some of you are first years, and I'm not sure what kind of experience you have had with Hep B United Philly, but we do work very closely with our medical and public health students in Philadelphia, and we'd love to have you join us at our events. Every year in May, we do a large Philadelphia awareness event to try and bring awareness about hepatitis B and increase prioritization. So you could see the top left, that is Councilman David O. He's a Philly City Councilman, and that's Mayor Michael Nutter. They both were at our May event. That was 3 years ago. And then in the middle here, this big picture with Oliver, our giant liver, that was from 2 years ago, where we had an event at City Hall, and we had over 100 people there, where we were talking about increasing awareness and letting our city council members know that there are a lot of people in Philadelphia with Hep B and they need increased services. So with that, our next event is going to be Thursday, May 19th. It is going to be from 9 to 9:30 a.m. We are having a press conference outside of City Hall. It's only a half hour. And we've got lots of press that will be invited. There will be city council members speaking. Actually, we've invited, I don't know if any of you know Edith Mitchell, but she's with the Jefferson Kimmel Cancer Center. So we've invited her to speak. Dr. Johnson, so the Assistant Health Commissioner, will be speaking. We hope you guys can attend. We will be sending out flyers very soon. And if you could join us, that would be great. And that is all I have. So if you wanted to unmute yourselves, I'm happy to answer any questions.
Okay, so first,
thank you.
So thank you again for speaking, Sherry. Like, we really appreciate it, especially because we know that you're not feeling well. So thank you for taking this effort. Do any of you have any questions for Sherry? Okay, I guess not.
No questions? Wow, that's never happened before.
I have a question, don't worry. You talked a lot about outreach to Asian Pacific Island communities, and it looks like a lot of your trans-related materials for them. Are you working on anything for African immigrant communities?
Yeah, that's a really good question. So yes. The big answer is yes, but with a caveat. We have a Hep B Foundation started a few years ago. We started a national coalition called CHIPO, which is the Coalition Against Hepatitis in People of African Origin. And we have about 50 partners around the country, and we're working to try and address hepatitis B in African immigrants. Now, that being said, we are about 20 years behind in African communities where we are in Asian communities. African immigrants in the U.S. are newer. They've, for the most part, and this is very true in Philadelphia as well, they have not been in the U.S. that long. They have, believe it or not, they have even more healthcare access. They tend to be significantly more underserved, and they don't have the same kind of community infrastructure that Asian communities have. So in cities that have high populations of Asian communities, they have built infrastructure, community-based organizations primarily, and social service organizations that serve those communities. In African communities, we haven't seen that yet. So because of that, and then also because of kind of the trust issue and lack of knowledge, we are having much harder time getting into the African immigrant communities than we did with the Asian community. So we are working on it, but we've got a long way to go.
Is there any research being done on a rapid test?
Yeah, that's a great question. I love that question. This is something we have advocated for years. And the short answer is no. We have reached out to a number of companies that make tests, and we have tried to advocate for a rapid test for hepatitis B, and what we have been told is that they don't see the market for it, and if they don't see a market for it, they're not going to make it. It's really unfortunate, and it's something that we can only do so much. We advocate for it, but it's really up to the companies, and they have been putting a lot of effort into HIV rapid tests and Hep C rapid tests. And so I wish I could say that there was a Hep B rapid test coming down the pike. I don't think it will happen that quickly, unfortunately. It would make life a lot easier.
Sure. So in your opinion, what do you think physicians can do to try to break down some of those barriers that prevent people from trying to talk about Hep B, especially amongst the Asian and African communities?
Yeah, I think physicians can play a critical role. So what we know is a lot of the barriers that Asian and Pacific Islanders face, they stem from myths and misunderstandings. And those myths and misunderstandings lead to fear of stigma and discrimination. There's a couple of myths that we have seen over and over again in our research. Remember, folks in the Asian communities, particularly those who are foreign born, they all had family members who died of Hep B and liver cancer, right? And they're scared of it. And so one of the myths is, it doesn't matter if I get tested or not, I'm going to die from it anyway, so why should I know? People are often told that there's nothing that can be done. You know, there's no treatment, or there's nothing we can do for you, so why bother? I think providers who can provide very, very simple but impactful information about hepatitis B, something as simple as, would you like to be tested for hepatitis B? There are treatments that can prevent cancer, and we can save your life with one simple blood test. You know, something that can help to overcome those myths and stigma. And I think a lot of it has to do with opening provider and patient communication, but not all of it falls on the provider. So, you know, a lot of it has to do, unfortunately, with the U.S., with our society as a whole and our stance on immigrants and immigration. People are very scared if they are foreign born. They don't want to be diagnosed with a reportable infectious disease because they're afraid that they'll be kicked out of the country. Whether that's true or not, you know, that's a real fear for people. So yes, I think providers can provide simple information to let people know that if they're diagnosed, there is something very easy that we can do so that they don't progress to liver disease. But I also think that as a society, we have to work to be more accepting and to, you know, hopefully in the future to change policy regarding immigration and healthcare access.
Any other questions? Good. Okay. Thank you very much for answering our questions, Sherry. I just want to talk about our Hep B screening event. That's okay.
Yeah.
Okay, thank you. So as you can see from Sherry's talk, there's a huge need for screening initiatives in our own Philadelphia community. So this year, APAMSA is going to host a free hepatitis B screening health fair in Northeast Philadelphia, primarily for the Vietnamese community. So Hep B United identified this community as really high risk because they haven't been screened for a number of years now. So we're going to be also taking their blood pressures and doing glucose monitoring for them. We're also going to have help from Penn dental students who will be doing basic dental screenings as well. We're also partnering up with Hep B United to connect folks who are testing positive for hepatitis B for vaccination and follow-up treatment. We're just not, you know, we will be transferring them to family. So the screening is going to be on Saturday, April 30th, and so we'll be sending sign-ups and more details about them on the Facebook group and by email. So if you're interested, especially if you speak Vietnamese, please volunteer. Thank you.
And for those, just to build on that, for folks who haven't participated in community screenings, they are very worth your time. I mean, it is amazing to get into the community and be able to kind of touch people and see firsthand the things that they face, and really to give and take and share with them. It's one of the best things that we do. So if you have a chance, it would be great if you can come.
Yeah, so if you're interested, just contact John and Nancy, and I think we sent you the Facebook page for that event soon as well, so hopefully a lot of you guys are able to come out. Alright, I think that's pretty much it. Let's give Sherry one last.
Okay, thanks guys. So is it okay if I stop? I'm going to stop the recording now, and then I'm going to close out. Is that okay with you guys?
Yeah, so thank you so much.
Thank you so much, Sherry.
Thank you. I hope I get to meet you in person.